Hello, I'm Dr. Deepak jayaprakash Kaddu. I'm a consultant neurologist and robotic surgeon and neuro-oncologist at Manipal Hospital, Whitefield, Bangalore. I'm working here as a consultant since last 3 years. I would like to talk on the prostate, so benign prostatic hyperplasia and the prostate cancer related questionnaires. So the men above the age of 50 years, the chances of developing the benign prostatic hyperplasia starts. So this is related to the imbalance between the testosterone and estrogen. As the age advances, estrogen increases and testosterone goes down, and which is related with the increase in the size of prostate. So approximately 50% of male above the age of 50 are having prostate related symptoms, and as the age advances, the percentage of male having this BPH related lower urinary tract symptoms will increase in the number. So if you come to the other part, like who all men after the age of 50 will develop the BPH, there is no fixed correlation or genetic predisposition, but you could say red meat diet or fatty diet or the recently ongoing fast food diet would have a certain amount of impact over the increased chances of BPH. So if you include antioxidants, green leafy vegetables will have lesser chances. But nothing has been proven completely with any randomized control trial. These are some of the studies which say it's like that. So when a male patient comes after the age of 40 to 50 to the OPD of urologist, we advise certain tests to diagnose whether patient is really suffering from prostate related symptoms. So 2 to 3 most commonly done tests are ultrasound with the post-void residue, in which ultrasound KV with post-void residue, in which we'll know the prostate size and the amount of urine remaining inside the bladder after patient voids. And second most important test is a uroflowmetry. So uroflowmetry is advised by the urologist, in which the patient is asked to drink water and urinate on a machine, and we will calculate the amount of voided urine with and Qmax and the Q average, the average urine speed, and we'll come to know whether the patient is suffering from the BPH related symptoms. So apart from that, the symptomatology of the patient, so which is a FUNPIS score, that is frequency, urgency, nocturia, and the poor stream, intermittency, sense of incomplete evacuation or straining during urination. So these symptoms will be enumerated by the urologist to diagnose whether the patient is suffering from BPH. So there are certain symptomatology and there are certain objective tests like ultrasound and uroflowmetry to diagnose the BPH. And we also order the serum PSA to differentiate whether these symptoms are related to BPH or a prostate cancer. As per the studies, there is no strong correlation like BPH predisposes to prostate cancer. No. So the answer is actually no. But when it comes to the severely progressing BPH symptom, sometimes it can lead to prostate cancer. But by and large, there is no strong correlation between BPH and prostate cancer. And in certain scenarios, when serum PSA is borderline and the prostate size is quite huge and we are confused the PSA is related to BPH or prostate cancer, we do a PSA density, which if it is more than 0.15, then we think there is a chance of prostate cancer, and we do further investigations like MRI or TRUS biopsy. If it comes below 0.15, we still think it is related to BPH. So yeah, so this is how we differentiate between BPH and prostate cancer with the relation to serum PSA. But by and large, there is no strong correlation between. So conventionally, the BPH has been treated. The first option will be always the medication. So medications will be divided into alpha blocker plus or minus 5-alpha reductase inhibitor, like previously it used to be finasteride, now dutasteride. And in the alpha blocker, silodosin, tamsulosin, and alfuzosin, depending upon the age of the patient and the requirement and the side effects profile of the patient. And then for the irritative lower urinary tract symptoms of the BPH, we give anticholinergic medications or beta 3 agonist medications. So these are the medication. Then we move on to the conventional surgical part. So TURP, so transurethral resection of prostate, mostly the bipolar or even monopolar, that has been a gold standard, and it is still one of the gold standard treatment for the benign enlargement of prostate when the medications fail or patient is non-compliant with the medication, or there are certain absolute indications for the surgery. So after the medication treatment for the benign prostatic hyperplasia, we have the surgical treatment. So in the surgical treatment, the long time gold standard is transurethral resection of prostate. So it can be bipolar or monopolar, preferably bipolar. So that has been a standard treatment. Now the laser has coming into picture nowadays. So it can mostly the laser treatment preferred when the prostate size is more than 150 grams of prostate, or even some urologists prefer to do HOLEP for most of their cases. So that is holmium laser enucleation of the prostate. Some surgeons also use thulium laser for doing the same. Holmium is preferred over thulium in most of the centers. Then there are certain treatment modalities which have newly come up. So amongst them is one is resin, that is water vapor is used to cause an coagulation necrosis in the prostate, and that treatment is used when the patient is young and the prostate size is 30 to 80 gram, and they don't want retrograde ejaculation as a side effect of the prostate surgery. Then is the urolift procedure, again the similar indication, young patients, not much prostate size, median lobe is not there, not in high bladder neck. In such cases, patient want to preserve the retrograde ejaculation, again you can use the similar modality. So these are two upcoming modalities. Apart from that, there are certain indications in which we do robotic simple prostatectomy when the prostate size is huge, and the HOLEP laser enucleation might be a lengthy procedure. So you better go for the robotic simple prostatectomy to reduce the urethral timeline causing the long-term urethral strictures complications. So these are the treatment modalities for benign prostatic hyperplasia. Medication plus surgical. Also, there is a radiological treatment like prostatic artery embolization, which can be done when patient is not fit for surgery and not responding to medication. Yeah, we can try that. Thank you very much. So here I conclude my talk.